Thank you for all attending, my colleagues, and thank you for MSD to give me a chance to be among my colleagues. Today we will speak about the benefit of early initiation of DPP-4 inhibitors class, which is very important class in management of type 2 diabetes. And especially we will highlight the role of Sitagliptin in management of type 2 diabetes from the view of cardiometabolic risk reduction. Let's go to our agenda today. We will speak about some point about diabetes and the role of DPP-4s, especially Cetagleptin, which is highly selective DPP-4 inhibitor, and the benefits over sulfonylurea and summary. Let's speak about cardiometabolic risk. Diabetes considered the major cardiometabolic risk and many factors contributing to cardiometabolic risk. If we can imagine that 85% of type 2 diabetes coming from obesity and overweight, and as well insulin resistance, which is highest in our clinic underdiagnosis, can lead to cardiometabolic risk. And also the life in the Gulf, especially sedentary lifestyle, physical inactivity, smoking, and because of the hot weather, the physical activity is very less. This all contributing to cardiometabolic risk, inflammation, and hyperlipidemia, and some genetic factors and family history, all contributing to increase the cardiometabolic risk and increase the global diabetes and the cardiovascular disease. And if we can see, the global burden of diabetes is very growing, and the incidence of diabetes suspected to be in 2045 be double, especially in some hot areas like Americas and Middle East and Africa. So if we can imagine in our Gulf, the first country worldwide in the prevalence of diabetes, Saudi Arabia, which represent about 25%, and our country in UAE, we have about 19%, according to the latest data of prevalence of diabetes, which is big among our population. This is all due to the factor we mentioned before of lifestyle and genetics and environmental and obesity, overweight. If we can imagine about the ideal basis of type 2 diabetes. In the past, before the recent guidelines show to us the importance and the difference pathogenesis of diabetes, we are considered diabetes before as a one disease, very simple disease, hyperglycemia, simply, and management in the past is only blood sugar control, hemoglobin A1C reduction. But the recent view of diabetes now give us 4 bases to control our patient. Management of diabetes now, not only hemoglobin A1C reduction. Management of diabetes now is hemoglobin A1C reduction, weight reduction. For obesity, as I mentioned before, 85% of type 2 diabetes happen due to overweight and obesity. Dyslipidemia management, especially LDL, and blood pressure control to be threshold for our diabetic patient, always blood pressure below 130/80. So if we achieve these 4 goals, this is meaning this type 2 diabetes management. So type 2 diabetes management is not only blood sugar control and the hemoglobin A1C target. There is other target for our patient for future and prevent the suspected complication in the future. So let's see every component individually, the benefit of weight reduction in type 2 diabetes. If we can imagine 1 kg body weight reduction associated with cardiovascular risk reduction, 6% in women and 3% in men, lowering both systolic and diastolic pressure by 1 millimeter mercury, improve the bad cholesterol, non-HDL cholesterol, and as well improve glycemic control. So this we can achieve from only 1 kg body weight reduction. So that's why in the guideline, they always motivate and recommend the weight reduction medication, or at least prevent the weight gain medication. So also the benefit of hemoglobin A1C reduction, we can imagine every 1% reduction in hemoglobin A1C, this can reduce long-term diabetes complication, 37% reduction of microvascular complication, 21% reduction of all causes of death related to diabetes, and 14% reduction in myocardial infarction. Also, blood pressure reduction as little as 2 millimeter mercury can reduce the risk of cardiovascular event by about 10%. Also, LDL reduction and major cardiovascular risk reduction, every 1 millimole reduction in LDL associated by 22% relative reduction in incidence of any major vascular event at 1 year, which is something very significant for our patient protection and for ideal treatment for our type 2 diabetes. So this is the pathogenesis of happen of diabetes, and there is a time zero of diagnosis of diabetes, which diabetes started by before the time of diagnosis. So beta cell decline of function and progressive nature of type 2 diabetes make type 2 diabetes and complication arises before diagnosis and ongoing by the course of disease due to pathogenicity and progression of type 2 diabetes. What we see here in this diagram, development of macrovascular complication start before diagnosis, and development of microvascular complications start after diagnosis. So it's not a simple disease to deal with at the time. We can wide our screening for pre-diabetic and people liable to have diabetes to control them or prevent occurrence or delay the occurrence of diabetes, which can help our patient for not have the early complication as much as we can. So achieving the target control of hemoglobin A1C less than 7 in one study among type 2 diabetic patients, it becomes challenging in many countries, even advanced countries. This is in Europe and in very popular, it's called Panorama in Europe country, about the achieving hemoglobin A1C on target less than 7. We will find many countries fail to achieve control. We have many countries, the maximum they can go for control is 40% of their patient to achieve target control of below 7. And this is due to many challenges in type 2 diabetes management and diagnosis and the clinical practice. The approach of treatment of diabetes in the past there is like symptomatic approach, which depend on we are intensify medication or change medicine and add another medication as intensify for our patient once the patient started to be symptomatic. And this is called failure approach. When we gave metformin, after failure of metformin and the patient started to be symptomatic, we go for second agent, and after second agent, patient failure and the patient started to become symptomatic, we change this. But the ideal approach, which is in the yellow line, it's hemoglobin A1C approach, which we are always keep change and intensify medication as early as possible, regardless of the patient's symptoms. We are only looking for hemoglobin A1C below 7. If the patient failed to achieve hemoglobin A1C below 7, we go for intensification as early as possible, and this can prevent the patient from future complications. So what are the challenges to achieve hemoglobin A1C in target? Education, motivation and support of the patient on self-management, adherence to medication and the complexity of medication, adherence to guidelines, personal feedback to healthcare professionals, and the effective use of information systems and developing a quality measure for diabetic management and to be patient-centered service for our patient. But the question here, always this is a very common question. What after metformin? What we will do after failure of metformin? When metformin alone is not controlling our patient and not get them to the target, what is the next? Here, according to the old guideline, after metformin, doctor is a decision maker. Like we are in the restaurant, you can choose the second agent according to doctor decision, no any recommendation. So you can go for your choice, like restaurant, you go for pasta, fish, whatever, like choices of medication. The doctor only is a decision maker and no special recommendation for the second agent after failure of metformin. But the recent guideline not give us the chance to make any other anti-diabetic agent to be added as a second line after failure of metformin due to many factors and due to study of the diabetes pathogenesis. And as I mentioned before, diabetes now management is not only blood sugar control. There is many other factors, cardiovascular factor, kidney factor, and weight factor, and many other factors. So that's why we will find after metformin, the line of treatment like GLP-1, SGLT2 inhibitors, and DPP-4 inhibitors, they have the greatest high recommendation of the green line because of the safety and achieving the all goals of type 2 diabetes management, including cardiovascular risk reduction and weight reduction and dyslipidemia management and blood pressure controlling, and have many function and many benefits for our patient. So the guideline now started to be recommend us according to the patient profile, according to cardiovascular profile, and according to safety for our patient, according to weight for our patient, not make more weight gain, which is lead to uncontrolling of our diabetes and pathogenesis of diabetes, and this all factor. And we will find here in the American Association of Clinical Endocrinology, in the monotherapy and dual therapy and the triple therapy, they put sulfonylurea at the bottom of the list. They are the least choices of medication due to the many side effects of sulfonylurea, as weight gain, as hypoglycemia risk, and as also pancreatic exhaustion and beta cell failure. So if we see the profile of anti-diabetic medication, we can find DPP-4 are very unique anti-diabetic agent because of their no side effect, maybe very minimal among all anti-diabetic, and no effect on the weight. There is no weight neutral, and also hypoglycemic risk is neutral, and cardiovascular and kidney also are neutral, except those adjustment in kidney disease according to stage of kidney disease, which we will highlight in our slide, which is the only DPP-4 doesn't need any adjustment in all stages of kidney disease is linagliptin. So here, as a class, according to American Diabetes Association, DPP-4 inhibitors, which is incretin enhancer, they have many advantages of no hypoglycemia, weight neutral, and very minimal disadvantage, which we not find in our clinic, mostly maybe every 2 years, 3 years, if you have simple case of any side effect, not like other anti-diabetic agents. Also, the mechanism of action of DPP-4 inhibitor enhances the physiological effect of incretin hormones, which improve islet cell function and improve as well glycemic control. And it have also improving incretin activity, which become prolonged, not degraded by intestinal lytic enzymes. So DPP-4 not only for diabetes control, not only for blood sugar control, we can think in the future, and there is ongoing studies about the benefit of DPP-4 inhibitors even beyond glycemic control. So it can help in inhibition of dyslipidemia. There is some in helping in endothelial healing, prevention of atherosclerosis, and improve the vascular function. About selectivity between the classes of the molecules of DPP-4 inhibitors, we will find the Cetagleptin, the highest DPP-4 molecule, have the highest maximum selectivity, 97%. We will find other agents like valdagliptin, allogliptin, saxagliptin, linagliptin. The selectivity of inhibition of DPP-4 enzymes, they are less than Cetagleptin. So the highest selectivity, it's in favor with Cetagleptin, which give us good chance for controlling glycemic control and the benefits of DPP-4 as a class. So here, according to FDA, Cetagleptin, the first FDA-approved DPP-4 outside United States, and can be used as a monotherapy and combination therapy. Monotherapy for people have any side effect or contraindication to metformin. Cetagleptin improve pancreatic function and increase insulin production, and also in the liver decrease hepatic glucose overproduction, which working in independent glucose manner. Here also, incretin hormone concentration in healthy adult subject, when we add Cetagleptin, it helps to increase the active GLP-1, and when we add metformin to Cetagleptin, it will help more and more to increase the total GLP-1 and the active GLP-1, and as well active GIP. So this all helps the incretin activity, which is very important for the cycle of controlling blood glycemic control, and as well also the cycle of improving cardiovascular disease. As we know, there is some DPP-4 inhibitors like saxagliptin, before they have the risk of heart hospitalization due to heart failure. And after TICUS study, we have now proved that the molecule of DPP-4, sorry for screening this issues. So the molecule of Cetagleptin have proved by TICUS study no increase in cardiovascular risk with Cetagleptin versus placebo in high-risk subject with type 2 diabetes, according to the American Diabetes Association in 2015. So also, here our rule as a physician to immediate treatment intensification to improve glycemic control in patients with type 2. As I mentioned before, in the slide of hemoglobin A1C approach and failure approach, the early intensification and the early control to target of hemoglobin A1C, regardless of failure and waiting up to failure and then intensify, this can help to delay and prevent the future complication of type 2 diabetes, which can make something good for our patient to prevent them and make the life expectancy for our patient better and better. And this is the rule here. If we have immediate intensification, have very good impact in hemoglobin A1C, and the delayed intensification also, this has become bad effect in hemoglobin A1C. Regardless of this molecule we added, we cannot reach the optimum always because we are delayed in decision. So early intensification and immediate intensification can help to protect from type 2 diabetes complication as early as we can possible, and this is our mission. There is some clinical efficacy and safety of Cetagleptin therapy in patients with not controlled on metformin alone. There is studies about Sitagliptin and Sulfonylurea, which is our today's discussion. American Diabetes Association risk of hypoglycemia always is be considered in management of type 2 diabetes and hyperglycemia. And always hemoglobin A1C below 7 and not go to hypoglycemia with non-hypoglycemic agent always can reduce the risk and increase the life expectancy and not affecting the possible future complication of our patient. Here also the cost and the severity of hypoglycemia can make our health system and health care resources utilization for our patient have many costs for us and burden for the economy of our, because patient always have healthcare professional visits and go to emergency according to the level of hypoglycemia, if severe, non-severe, or no hypoglycemia. If with no hypoglycemia, number of hospitalization less, number of healthcare professional visit less, and number of emergency visit less, which can save some of the cost and economy for our country. So to achieve this, we can help our countries and utilization of the healthcare system in our communities. So there is clinical trial of Cetagleptin versus sulfonylurea. This as part of clinical development program, Cetagleptin has been compared in randomized controlled clinical trials of up to 2 years duration with glipizide and Glenbride. This one study addition of Cetagleptin or glipizide in patient not controlled on metformin. So in one arm, there is glipizide, 5 milligram titrated up to maximum 20 milligram per day. And in other arm, there is Cetagleptin, 100 milligram. And this is for 2 years. According to the same efficacy, along 2 years, the hemoglobin A1C, no inferiority or superiority for class over the other. They are similar in controlling hemoglobin A1C. No significance of any difference between the two molecules. So as the point of hemoglobin A1C reduction, they are similar in these 2 years survey. So as regard weight, body weight, there is more weight reduction in the arm not using sulfonylurea on Cetagleptin, very significant. And as regard hypoglycemia, there is very minimal hypoglycemia in the arm of Cetagleptin over sulfonylurea glipizide. So in glipizide, there is weight gain. In glipizide, there is more hypoglycemia risk. So according to age, using the glipizide and Cetagleptin in age group more than 65 years and below 65 years, both arms of glipizide, they have risk of hypoglycemia, even more than 65 years or less than 65 years, but both arms of Cetagleptin in age group less than 65 and more than 65, they are at the same low risk of hypoglycemia. So this is another, I will go very fast because of the time, for comparison between Cetagleptin and the Glenbride. Here, hemoglobin A1C, same control. No, they are same according to hemoglobin A1C, but also there is less hypoglycemic risk with Cetagleptin and body weight reduction with Cetagleptin in comparison to Glenbride, which have weight gain and more risk of hypoglycemia. And all in favor safety of Cetagleptin over Glenbride as regarding hypoglycemia. So in this also study, with this study, there is comparison between Cetagleptin metformin and sulfonylurea metformin. The number of patients continued medication and have good maintenance of medication with the arm of Cetagleptin metformin is highest than people with sulfonylurea metformin due to hypoglycemia and weight gain. As regard hemoglobin A1C, as I mentioned, they are similar or maybe better in the arm of Cetagleptin. There is little difference and significance of Cetagleptin, but considered non-significant. So they are same as a control, but continuation and risk of hypoglycemia weight gain is more. Also in hypoglycemia and weight, in favor of arm of Cetagleptin metformin, less hypoglycemia and more weight reduction, which is benefit our patient, as we mentioned about the benefit of weight reduction. So in comparison between DPP-4 and sulfonylurea, there is low risk of hypoglycemia in DPP-4. In weight, they are neutral, or in some time weight loss benefit, and in sulfonylurea, weight gain and increased risk of hypoglycemia. So this is in kidney disease about titration and the dose of using Cetagleptin versus the sulfonylurea. Here we can find, according to GFR, if GFR between 30 to 50, we can use Cetagleptin 50 milligram, and blue 30 GFR, we use Cetagleptin 25 milligram. What about the effect of hemoglobin A1C of 150 and 25 according to GFR? We will find very good, very impressive that 100 milligram once daily equal to 50 once daily as regard hemoglobin A1C reduction, equal to 25. This is in end stage renal disease. This is according to kidney disease. For normal people or doesn't need to reduce the dose, GFR more than 60, no titration. Hemoglobin A1C same, even though we down titrate Cetagleptin to 50 or 25, hemoglobin A1C becomes same with all these doses of Cetagleptin, which is something unique to Cetagleptin. Unlike linagliptin, which can give to all kidney disease, but by the same dose. Here we can give only 25 milligram of Cetagleptin of end stage renal disease, have the same efficacy of the 100 milligram of Cetagleptin, and as the same efficacy of linagliptin by the maximum dose of 5 milligram. Okay, our home message here to be Cetagleptin potent selective DPP-4 inhibitor, once daily, one significant reduction in A1C, sustain the A1C reduction, improve in multiple measures of beta cell function compared to sulfonylurea. Cetagleptin superior in improving beta cell function, and in comparison to sulfonylurea, it can have less hypoglycemia and more weight reduction, and less risk of hypoglycemia and more weight reduction. Once we choose our medicine for our patient to tailoring the art of management of type 2 diabetes, always we look to right drug in right dose in right time in right way. Thank you.